Hello, my name is Dr. Shylesh Kumaran Aravindan, and I'm a paediatric anaesthetic consultant and a paediatric pain lead at the Royal London Hospital, which is part of Barts Health. I'm giving this talk in order to share knowledge with our Ukrainian colleagues about our analgesic techniques for paediatric trauma. I am sure a lot of this will be familiar to our colleagues in the Ukraine. However, I hope that there is something practical that they can take from this. Why is paediatric analgesia important in trauma? The first message that it needs to be multimodal for it to be effective. As I'm sure you know, opioids have a degree of tolerance to them and thus make maintaining good analgesia harder. Therefore, it's always important to use simple analgesics, other adjuvants such as NMDA antagonists, potentially neuropathic agents if you feel that there is a neuropathic element to the pain, or if you know that there is a nerve injury. Another very useful adjuvant are local anaesthetic techniques, and these can either be single shot nerve blocks, central neuroaxial techniques, or local anaesthetic infiltration catheters. Why is it important? It's important in different settings of trauma. For neurotrauma, you want to decrease the chances of secondary brain injury. One of the techniques to do that is to decrease the intracranial pressure. By ensuring good analgesia, you're decreasing the cerebral blood flow, you're decreasing the oxygen consumption, therefore decreasing the chance of cerebral tissue hypoxia. All of this will lead to a decrease or maintenance of a normal intracranial pressure. For both abdominal and chest trauma, what you want to do is decrease the stress response, which has its own physiological effects, such as water retention. If you have an active bleeding patient, you want to decrease the blood pressure in order to facilitate permissive hypotension. Postoperatively, you want these patients to deep breathe, cough, clear their secretions, and thus decrease the chances of postoperative lower respiratory tract infection. We'll start with simple analgesics. At the Royal London, we use paracetamol at a dose of 15 mg per kilogram in the over 10 kilo child intravenously. If they're under 10 kilograms, we use 10 mg per kilogram 8 hourly. If you're extubating them and you're going to have them eating and drinking post-operatively, you can do 15 mg per kilogram 6 to 8 hourly. As I'm sure you know, with non-steroidal anti-inflammatory drugs, they do prolong coagulation, and therefore you need to be careful with an inactive hemorrhage. If the surgeon has achieved hemostasis and they're going to be eating and drinking afterwards, you can prescribe ibuprofen at 7.5 mg per kilogram 6 hourly. And that's greater than 3-month-old. Between 1 month and 3 months is 5 mg per kilogram 6 hourly. We don't prescribe it here at less than 1 month. Opioids can be given preoperatively either intravenously or intranasally. The benefit of giving it intranasally is if the patient is too distressed to accept an intravenous cannula. It can calm them down, it can give them analgesia in order to give the team time to site an intravenous cannula. Postoperatively, it can be given either intravenously or orally if they're extubated and can eat and drink. Preoperatively opioids, and these are usually given in our emergency department. We give intravenous morphine, 50 to 100 mics per kilo to effect. Intravenous fentanyl, which is 0.5 mics to 1 mic per kilo to effect. And as I mentioned before, you can give intranasal opioids, and an example is intranasal diamorphine at 0.1 milligram per kilogram. In terms of intra-op opioids, I'm sure you already do this. But for morphine, you can give 0.1 milligram per kilogram titrated to effect. Fentanyl, 1 mite per kilo. We often go up to 3 mites per kilo if we're considering extubation in our trials. We can also consider a remifentanil infusion. If you feel the patient requires a lot of analgesia, particularly for the neurotrauma cases that might affect their intracranial pressure, you can run this, but beware it does drop your blood pressure. For bleeding cases, I wouldn't run remifentanil as, again, it drops your blood pressure and may mask the clinical picture. If you run remifentanil at a high dose for a prolonged period, and we're looking at doses above 0.2 mites per kilo per minute, there is a chance they have acute hyperalgesia. They may need higher than normal doses of opioids towards the end of the procedure and post-operatively. So this is something to watch out for. In terms of post-operative intravenous opioids, we use either nursing-controlled analgesia or patient-controlled analgesia, depending on the neurodevelopment of the patient. I'm just going to show you some examples of prescriptions or guides to prescriptions that we have. Essentially, they're made up of the dose that you would prescribe for the patient and the background infusion, which we tend to always run, and boluses as well. We also have here guides for more the junior doctor staff and the nursing staff, looking at assessing pain scores, sedation scores, other drugs that you need to prescribe, and what to look out for in terms of their respiratory mechanics. We have another example here for neonatal morphine, which has altered parameters, and fentanyl as well. You may have patient-controlled analgesia pumps in the Ukraine. In the UK, we use IVAC PCAM pumps. The patients are seen twice a day by either the pain team or the anaesthetic registrar in the morning and evening, and this is to ensure that the patient is well analgesed, to make sure they're well in terms of the side effects of the opiate, but also that the pump is doing the job effectively and delivering the right medication. Other drugs you can use are NMDA antagonists such as ketamine, 0.5 milligrams per kilogram in titrated doses. You may have already used ketamine as the induction drug for your anaesthesia, and that will have an analgesic effect as well. As I mentioned before, you can give neuropathic agents if you either suspect a nerve injury or is confirmed in, for example, a wound exploration in the table. Here at the Royal London, we use gabapentin. As I'm sure you know, we step it up. So on day 1, it's 5 milligrams per kilogram once a day, which goes up to twice a day, which goes up to 3 times a day. The maximum dose is 1.8 kilograms daily. If the drug is going to continue for a long time, particularly after 6 weeks, we will titrate down the dose. We will never stop it suddenly. As mentioned before, local anaesthetic techniques are a good adjuvant to multimodal analgesia. Central neuroaxial techniques have their place, but here at the Royal London we tend to go more for peripheral nerve blocks if we can. There have been large studies, particularly in America and France, which have had up to 100,000 patients, which shows that complications related to local anaesthetic techniques are 6 times more likely in central neuroaxial techniques. I'll also give a few more reasons for why central neuroaxial techniques may not always be the best choice, although they still do have their place, so I'll make this clear. A common block we do is for lower limb fractures, particularly femur fractures, and that is the Fascia Iliaca block. We tend to use ultrasounds for all our blocks, but you can use a landmark technique, and I'll give you a website which can either refresh you if you already know it, or can teach you it if you don't know it. In terms of the ultrasound picture, you are looking for the Fascia Iliaca, which is this line demarcated by the white arrows here, and you place the needle just underneath it between the iliopsoas and the Fascia Iliaca. In the more adult-sized patients, you may feel two pops, one going through the fascia lata, which is just above the Fascia Iliaca, then the Fascia Iliaca itself. However, in children, you may not feel the pops as distinctly. And you're looking to place a volume of local anaesthetic in this space here. You can potentially go for a femoral nerve block, which is injecting more medially closer to the femoral nerve. And this will result in a denser block, which is longer lasting. In terms of regional anaesthesia, at the Royal London we tend to do transverse abdominis plain blocks, the tap block, but you can also do the rectus sheath block. In our institution, we don't site the rectus sheath blocks ourselves. We get the surgeons to insert rectus sheath catheters, but I'll show you the ultrasound picture for that anyway. In terms of the tap block, you place the ultrasound probe on the lateral aspect of the patient. You insert a needle and you're going through the external oblique, internal oblique, and you're injecting local anaesthetic between the internal oblique and the transverse abdominis. If you have the skill, you can also place a catheter in this space and do a continuous either infusion of local anaesthetic, or you can get a junior doctor or a trained ward staff to place local anaesthetic down the catheter. However, the person doing the procedure does need to be trained and does need to have the ability to look out for signs and symptoms of local anaesthetic toxicity or accidental intravascular placement of local anaesthetic. As I said before, we do not site the rectus sheath blocks ourselves at the Royal London. We get the surgeons to put in rectus sheath catheters, and we manually bolus them every 6 hours, and we use the anaesthetic registrar and the pain nurses to do this. However, if you are going to do a single shot block, what you do is you place the ultrasound probe just lateral to the umbilicus, look for the rectus abdominis, you place the needle down through into the posterior aspect of the rectus abdominis, and you're looking for the rectus sheath, and you're looking for lifting off of the rectal sheath, of the rectus abdominis. If you find that there's intramuscular injection, you just move the needle further along until there isn't so. This is the website you can use to look for regional techniques in terms of the ultrasound pictures, the relevant anatomy, the technique itself, how much local anaesthetic you want to use, and practical aspects, just the position of the patient. So epidurals, as I mentioned before, they do have their place, particularly in chest trauma where there's rib fractures or quite marked abdominal trauma where you'd like the patient to deep breathe and cough post-operatively. However, there are lots of caveats which do prevent us from doing paediatric epidurals as a common procedure in our centre. If the patient is having a hemorrhage, they're at risk of coagulopathy, which has implications for insertion of the catheter or removing the catheter, even if it's a few days post-operatively. They may need their coagulation checked. If there is bowel perforation, there's a risk of bowel contamination and a risk of sepsis, therefore an increased risk of an epidural abscess or at least a epidural catheter infection. Another aspect is time. When these patients come to theatre, it is usually in a time-critical fashion, and you often don't have time to turn the patient lateral. may not even be practically possible to turn the patient lateral if they have a bleeding point to insert an epidural. Another aspect is post-operatively there's a reduction in the systemic vascular resistance, which can cause hypotension, which may cause diagnostic confusion, which may be confused with the vasodilation may be confused with either bleeding or hypovolemia and may make the patient harder to assess. Therefore, the benefit of the epidural must be large enough to not only outweigh the risks of an epidural itself, such as nerve damage, paralysis, etc., but also about the holistic picture of the trauma case. As I said at the beginning, analgesia is not only important for the patient's comfort, there are many physiological benefits to good pain relief. And multimodal analgesia should be the mainstay of any analgesic technique. Even if the patient is going back intubated to intensive care, if the plan is to extubate them soon, they may benefit from a nerve block or an epidural prior to extubation. But this has to be a multidisciplinary team decision. Thank you. If you have any questions or any comments, please do email me at this address. As I said before, I'm not familiar with Ukraine practice, and you may already have a lot of these techniques in your arsenal. But I hope it has given you a basis for what we do at a major trauma centre in London. Thank you.